As You Think, So Shall You Become, A Look at Cognitive Theory by Arturo Calderon, Erika Fierros, Gordon Hodges, and Kira Russo. A brief historical background on cognitive theory. Alfred Adler. In the early 1900s, he developed a holistic approach of psychotherapy and stressed the importance on how thoughts influence our behavior. Albert Ellis. In 1956, he published a paper on rational psychotherapy. He developed the ABC model to explain the relationship between our thoughts, emotions, and behaviors. Aaron Beck. In the 1960s, he showed how irrational thoughts are linked to problems such as anxiety and depression, and developed cognitive therapy, which is the foundation to CBT. Cognitive theory practice principles. Cognition is the process of learning and attaching meaning to our experiences. From this process, we develop schemas, which are our underlying cognitive structures or core beliefs, which originate from our childhood. Based on our core beliefs, we will experience automatic thoughts, which are our immediate thoughts after any event. Some of these thoughts are irrational when they are maladaptive or lead to dysfunctional emotional or behavioral problems. Cognitive restructuring is the process of helping clients recognize their irrational thoughts, dispute them, and foster healthier or more positive ways of thinking, which in turn will have a positive effect on their behaviors and/or emotions. Some of the most common irrational thoughts include overgeneralization or reaching a conclusion with not enough evidence, dichotomous thinking or seeing everything as black or white, personalization or taking things too personal, and catastrophizing or thinking the worst case scenario in every situation. The therapeutic relationship in the cognitive realm is based on collaboration. The therapist acts as a trusted teacher, trainer, and coach who enables the client to actively participate in solving problems and meeting goals.
Aaron Beck's cognitive theory became his practice model cognitive therapy and is generally referred to as cognitive behavioral therapy because of the theory's utilization of behavior interventions in addition to cognitive techniques for modifying distress-causing thought patterns. In 2012, the National Institutes of Health published a review of meta-analyses concerning CBT's application to a wide variety of problems. The following is a summary of findings of CBT efficacy from this report. Findings will be bottom lined for the sake of available time. The meta-analysis revealed that cognitive behavioral therapy is an effective treatment modality for addiction and substance use disorder, schizophrenia and other psychotic disorders, depression and dysthymia, anxiety disorders, somatoform disorders, and eating disorders. Cognitive behavioral therapy was found to be ineffective as a standalone treatment for those with bipolar disorder, but yielded positive effects at post-treatment. Cognitive behavioral therapy also improved relapse delay and prevention. The meta-analyses also revealed that cognitive behavioral therapy is effective in treating insomnia, personality disorders, anger and aggression, criminal behaviors, general stress, distress due to general medical conditions, chronic pain and fatigue, pregnancy complications, and female hormonal conditions. The meta-analyses discuss cognitive behavioral therapy's success in treating vulnerable population issues for children and elderly adults. Other sources discussed cognitive behavioral therapy's success in treating issues related to minority ethnicities and foreign nationals.
As it is known and mentioned by Langer and Leeds 2015, cognitive behavioral therapy is a counseling treatment program that has been implemented by social workers and others to aid those in the helping professions to attend to psychological distress. There are many strengths to this type of therapy that include many benefits for the client. These strengths encompass both behavior therapy and cognitive therapy. One beneficial and strengthening factor of cognitive behavioral therapy is that by applying a CBT approach, this can assist clients to accomplish their goals by changing how they think, which in turn induces new choices, which can lead to new behaviors which cause clients to behave, think, and feel differently, as mentioned by Wright, Bosco, and Faith. A strength of this therapy can include a session example in which the therapist has the client break down the thoughts, feelings, and behaviors that can find the client in a deleterious cycle and learn strengthening skills and strategies that can be employed in the client's everyday life to help them cope when they find themselves falling into a deleterious cycle. Further strengths include cognitive behavioral therapy can be completed in a short period of time compared to other talking therapies. With cognitive behavioral therapy being highly structured, it can be provided in different formats, including groups and computer programs, just to name a couple.
Cognitive theory does not explain physical symptoms such as insomnia or pain that accompany cognitive distortions. These symptoms are tangible, valid, and worth considering. Cognitive theory gives less consideration to meso or macro systems of influence, so family systems, a lack of access of resources in the community, and systemic issues all apply here. Cognitive therapy may not treat the whole psychological issue because of its emphasis on rationality over emotion. This can contribute to repression and denial of feelings in the client. Cognitive therapy may not be as effective for clients with any of the following: difficulties with cognitive reasoning, whether they're young, old, have learning disability, etc. If they have a complex diagnosis, like something like personality disorder, or if they have multiple diagnoses. Certain personalities, like if they're very angry or if they have a very rigid way of thinking, may not work well with cognitive therapy. And if they're from a different culture, some cultures value emotions more than logical processes, and this might not be a good fit for the client. Cognitive therapy can mimic colonization by requiring clients of marginalized groups to adapt their ways of thinking based on what the practitioner misunderstands as dysfunction. Cognitive therapy can create an imbalance of power in the client-therapist alliance. The practitioner's role is very directive, and the techniques are very specific, so the client may feel overpowered, misunderstood, and ultimately not responsible for the outcome of their therapy. And lastly, cognitive therapy can be difficult for some practitioners if they are less assertive, or if they perform a flexibility in their practice. Some practitioners report burnout from the repetitive nature of cognitive therapies.